Welcome to Midlife Clarity with Dr. Tracy Page, a podcast for women over 40, navigating hormones, metabolism, strength, and confidence in midlife. Midlife is the moment you start asking bigger questions and expecting better answers. This is where we stop minimizing symptoms, dismissing perimenopause and menopause changes, second-guessing ourselves, and accepting this is just how it is. Instead, we get informed. We get curious. We get clear. Because midlife isn't about hot flashes or hormone shifts. It's about energy, strength, metabolism, relationships, identity, purpose, healthy aging. On this podcast, Dr. Tracy Page blends evidence-based medical insight with honest conversations to help you understand what's happening in your body, support your hormones, strengthen your metabolism, and build lasting confidence in this next chapter. You deserve clarity about your health, and clarity changes everything. Here's Dr. Tracy Page.
Hi, I'm Dr. Tracy Page, and welcome to Midlife Clarity, where we're seeking clear answers to things that are important to you and making sure that you're getting the information you need. And right now, we're doing a peptide series. Today, we're going to talk about Thymosin Alpha-1, rebuilding the immune system after 40. I'm super excited to talk to you about Thymosin Alpha and your thymus gland because we never talk about it, and you're going to be pretty surprised to hear some of these statistics. Okay, so my patient Karen, she's 49. She came into my office last fall with a list of every infection she had caught in the previous 8 months, and there were a few. She had counted them all, she had written them down, and she wanted me to understand that something she felt has actually changed. In January, so this was last year, she had a sinus infection that lasted 3 weeks. Then in February, a stomach bug that knocked her out for 5 days. In April, she had what she thought was COVID, but she tested negative 4 times. Now, she did say she lost her taste anyway, and it didn't return for almost 2 months, but she never tested positive. In June, she had strep throat. In August, bronchitis that actually turned into pneumonia. And by the time she came to my office last October, she'd been on antibiotics 3 times in the prior 12 months because she had something in December the year before, and she was carrying a fatigue that she said no amount of sleep would fix. Now, she also told me, just in passing, that she had been diagnosed with Hashimoto's thyroiditis at age 41. Her thyroid antibodies were elevated. She had been on a low dose of levothyroxine for years and had seen an endocrinologist, and she was what she thought was stable. She also had occasional eczema flares, especially after stress, and she had never quite recovered from her COVID infection. In 2022, she still had brain fog. She had exercise intolerance. She didn't have the same stamina. She wasn't able to do the same things. And her heart sometimes even raced for reasons she couldn't even identify. Here's what nobody explained to Karen, and what I see often in my practice, is that her infection pattern, her autoimmune disease, her lingering long COVID symptoms, and her chronic fatigue were not separate diagnoses. They were the same diagnosis expressing itself just in different organs. They were all symptoms of an immune system that had quietly stopped working the way it used to, and the central organ responsible for that decline had been shrinking inside her chest, of all places, since she was a teenager. By the time Karen turned 49, the gland that had trained her immune system since birth, which is her thymus gland, was approximately 90% gone. It had been replaced slowly and silently by fat. This is normal aging in all of us. It happens to every single one of us. Nobody had told Karen because nobody talks about it. We talk about menopause. We talk about declining estrogen, as we should. I mean, these are important topics. But we do not talk about the fact that the most important gland for immune function is actually fading away in plain sight. And there is a peptide that takes over the conversation when the thymus gland can no longer have it. And that's what we're going to talk about today. We're going to talk about that peptide, Thymosin Alpha-1. It has been studied in over 4,400 patients across more than 80 clinical trials. It has been used in 35 countries for over 30 years. It is one of the most well-validated immune-modulating peptides in functional medicine. And it has the closest thing we have to giving the midlife immune system a chance to work. By the end of this episode, you're going to understand exactly what happened to Karen's immune system, what's happening to your immune system, and how thymosin alpha-1 helps a body that has stopped bouncing back finally have the ability to bounce back again. Okay, let's talk about that gland and how and why your immune system has changed. I'm going to tell you about the organ you almost certainly do not think about. And like I said, almost no doctors will mention this to you, and this has been disappearing inside your chest since you were age 14. The thymus is a small, butterfly-shaped gland. It sits just behind your sternum and right above your heart. In a child, it's a robust and active gland. It is where native T lymphocytes, the cells responsible for nearly every adaptive immune function in your body, are educated. They go to the thymus to learn what it is that is you and what is foreign, what to attack and what to leave alone, when to mount a response and when to stand down to something. The thymus is still, quite literally, the boarding school of the immune system where everything is taught. And here's what almost nobody tells us. The thymus begins to shrink at puberty, and by age 30, it is significantly atrophied. By 50, it's mostly gone, and by 70, it's largely fat tissue with a few residual functional cells. This process is called thymic involution, and it happens to all of us, regardless of how clean our diet is, how often we exercise, how much we sleep, and how committed we are to our health. Okay, here's the numbers. The thymus decreases in size approximately 3% per year from birth until middle age, and then at 1% per year thereafter. That means by the time you're 50, the active thymic tissue you have left is a small fraction of what you had at age 14. And like I said, nobody ever tells us this. So native T cell output, the production of fresh, well-trained immune defenders, drops in parallel. Recent thymic immigrants, the term researchers use for newly minted T cells, are a small fraction of their childhood numbers by midlife. The T cells you have at 49 are largely the ones you had at 25. They're just now older, more exhausted, and with a more limited repertoire of what they recognize. This is why the elderly are more susceptible to infection. This is why vaccine responses decline with age. And I'm not advocating vaccines or not advocating them in this podcast. I'm just using that as an example of what happens as we get older. It is one of the reasons your flu shot is less protective at 65 than it was at 35, if you choose to get them. This is why cancer becomes more common in older adults and why immune surveillance against early tumor cells is impaired. This is why autoimmunity sometimes worsens with age. The immune system, with fewer well-trained T cells, becomes less capable of distinguishing self from non-self. The phenomenon has a name. It's called immunosenescence, and it has a paradoxical companion. It's like inflammaging aging. So your inflammation or inflamming aging is another term, a companion term. As immune function declines on one hand, low-grade chronic inflammation rises on the other. Those are the companions. The system swings between under-responsiveness and over-responsiveness, and neither extreme is healthy. Think of your thymus as an elite boarding school, where every immune defender went to learn its job. In childhood, the school is full. There are professors, classrooms, a curriculum, an active student body. Naive T cells arrive. They get trained for years, and they graduate as competent, self-tolerant, threat-recognizing defenders. By midlife, that school is mostly closed. The buildings are still there, mostly filled with fat now, but the active classrooms are few and the professors are retiring. The few graduates leaving the school, remember those naive T cells who showed up, are using a curriculum that hasn't been updated. The T cells they're training don't know how to recognize newer threats, but thymosin alpha-1 is the visiting professor, let's call him that, who keeps the most important lessons alive even when the school can't. It restores the signal the thymus gland normally would produce. The graduates that do leave are then better trained because of it. But of course, there's a hormonal layer to all of this. As if the thymic involution alone weren't enough, then perimenopausal hormonal shift makes the picture, you got it, even worse. Estrogen and progesterone are immune-modulating hormones. As estradiol fluctuates and declines through perimenopause, immune function shifts. And I've seen this. I've seen women get hormones started, start doing great, come off of hormones and have immune problems, get back on hormones and start to feel good again. I mean, and their immune system, I always say that when women lose their hormones, autoimmune rears its head. And I've seen it so many times. So as estradiol fluctuates and declines through perimenopause, immune function shifts. Some women see autoimmune flares for the first time in their 40s. Some see chronic infections that won't resolve, and some see allergies returning that they haven't had since adolescence. Estrogen also influences how aggressively the immune system responds. Women have generally a more robust immune response than men, which is why we have stronger vaccine reactions, faster infection clearance, and also higher rates of autoimmunity. When estrogen starts falling, the protective immune response also then begins to weaken. But there's that inflammaging layer that I said that, that co-companion. And underneath all of this, there's a slow accumulation of what we call senescent cells. Cells that have stopped dividing but have not died. Those senescent cells, they secrete inflammatory signals, and they do so constantly. This is the senescence-associated secretory phenotype, and we call it short SASP. It's the part of why a 50-year-old's baseline inflammation is higher than a 25-year-old, even if they look exactly the same on the outside. So Karen's pattern: 4 infections in 8 months, autoimmune disease, long COVID, chronic fatigue. It isn't random. It's a textbook expression, I would say, of a midlife immune system that has lost its central regulator and is now running an open loop and can't function. So what is actually thymosin alpha and why the body already makes it? So thymosin alpha-1 is a 28 amino acid peptide that is naturally produced by the thymus gland. It was first isolated and synthesized in 1977 by Dr. Alan Goldstein, who spent decades characterizing its mechanism. Like BPC 157 and also like larazotide, it's not a foreign chemical. It is a molecule your own body makes, just in dramatically smaller quantities by midlife than you did in your youth. And here's what makes thymosin alpha-1 so distinctive. It does not directly kill pathogens. Nope. It does not directly suppress your inflammation, so it doesn't work against inflammation. It does not directly attack tumor cells. What it does is it reestablishes the conversation between your innate immune system and your adaptive immune system and gets them working. So what's the mechanism? It's pretty elegant. Thymosin alpha-1 binds 2 specific receptors on what we call dendritic cells: the toll-like receptor 2 and the toll-like receptor 9. And toll is T-O-L-L. Toll-like receptor 2 and toll-like receptor 9. Dendritic cells are the immune system's, let's say, Boy Scouts. They patrol the body, encounter potential threats, and bring information back to the lymph nodes where they educate naive T cells on what is happening. When thymosin alpha-1 activates these toll-like receptors, dendritic cells start to mature. They upregulate the molecules they need to present information to T cells. They drive the differentiation of naive T cells into specific subtypes the body needs. So the body needs CD4 plus helper cells and CD8 plus killer cells, regulatory T cells that prevent autoimmunity. The molecule restores the orchestra of the immune response. Thymosin alpha-1 also increases what we call interleukin-2, interleukin-3, and interferon gamma. These are 3 chemical signals that immune cells use to talk to each other. They have their own language. It improves the CD4 to CD8 ratio. It enhances natural killer cell activity. It does all of this without triggering the kind of broad inflammation that other immune stimulants produce. Most importantly, it works bidirectionally. In an underactive immune system, someone with chronic infection, immunodeficiency, or vaccine non-response, it begins to stimulate. In an overactive immune system, someone with autoimmunity or chronic inflammation, it modulates and balances. This is why it's been used safely across such a wide range of conditions. So I'm going to explain that concept in an analogy. So imagine your immune system is like a thermostat. So it's like a thermostat that has lost its calibration. So in one room, it's freezing, and we'll call that immune deficiency, chronic infection, things you can't shake. In another room, it's overheating. We'll call that autoimmunity, allergies, inflammation that won't quit. Okay? Most immune drugs either push in one direction. Steroids, they will cool the whole house, or stimulants, they'll overheat the whole house. But thymosin alpha is different. It doesn't push the temperature. It actually recalibrates the thermostat itself so the system can read the actual conditions and then respond appropriately. This is why it works for both Karen's chronic infections and her Hashimoto's. It's the same thermostat with different problems. I hope that helped. Okay, the clinical track record. Thymosin Alpha-1 has been evaluated in over 4,400 patients across more than 80 clinical trials. It has a more than 30-year history. It's been studied in chronic hepatitis B, hepatitis C, in HIV adjunct therapy. It's been studied in sepsis and ICU setting, in cancer immunotherapy as a combination agent with the checkpoint inhibitors, in chronic fatigue syndrome, in autoimmune conditions, in vaccine non-response in elderly populations. So quite a few clinical scenarios. It received FDA orphan drug designation for hepatitis B in 1991, one of the earliest biological peptides to receive that classification. It is approved as a prescription medicine in 35 countries, marketed under the trade name and as Zadaxin, Z-A-D-A-X-I-N, Zadaxin. In the United States, Thymosin Alpha-1 is not approved as a finished pharmaceutical drug, but it has been compounded and used clinically by functional and integrative medicine physicians for many years with a remarkably clean safety profile. As I discussed in episode 9, it's been compounded and clinically used. The FDA Category 2 reclassification April of 2026 has shifted the regulatory landscape, and the July PCAC meeting will determine its formal status going forward. For now, it remains accessible through licensed compounding pharmacies under physician supervision. So again, I'll reiterate, licensed compounding pharmacies and physician or provider supervision. The safety profile across that 4,400 patient experience, it's pretty striking. The most common side effects are mild injection site reactions and occasional transient fatigue. Serious adverse events are rare. Unlike most immune therapies, it does not appear to drive autoimmunity, even in patients who already have autoimmune disease. This is the part that makes it so useful in midlife women who carry a disproportionate share of the autoimmune burden in our population. So I didn't know how powerful this peptide was. And so when I first opened Wisconsin Institute of Functional Medicine, otherwise known as WIFM, I had a patient who actually came into my clinic in a wheelchair, and she had received a vaccine, and I don't need to mention which vaccine it was. But she had had a history of Guillain-Barré. That's where you start to lose function, so muscle function from your extremities inward. And so your muscles slowly begin to weaken to the point that some patients have to go on a respirator. So she had this a long, long time ago, probably 10 years before she saw me. She had a vaccine, and when she had the vaccine, she had recurrence of this condition. And that's why she was in a wheelchair. So she came to me and she wanted me to help her. And I remember talking to my husband, and I'm like, I'm not sure. Like, I don't know if I can help her. Like, I don't know what to do, but it's just, this is an immune reaction. Like, this is her immune system. So, well, you know what I gave her? Thymosin alpha. And you know what? Today, she is still my patient. I've probably seen every member of her family, all of her friends. And she walks and talks, and she's great, and she's healthy. And all that time that I've taken care of her, she's lost 30 to 50 pounds already. She's turned her whole life around health-wise, and she wasn't unhealthy when I met her. She just wasn't able to walk on her own 2 feet, and she was weak, and it was just crazy, all the things that happened to her after she had a recurrence of this diagnosis. So it is a pretty powerful peptide. At least I've seen it be pretty powerful, and I could tell you at least a dozen more cases, not maybe as severe as hers, but definitely with some miraculous outcomes. Okay, so what thymosin alpha actually treats and where it shines. I'm going to walk you through the clinical situations where thymosin alpha makes the biggest difference, because the breadth of this peptide is, it's generally remarkable. And like I just told you, that story was pretty crazy. Okay, recurrent and persistent infections. This is the textbook indication for midlife patients. The woman who catches every cold the kids bring home and shakes none of them. The patient with chronic sinus infections that keep coming back despite multiple antibiotics. The patient with recurrent UTIs, recurrent yeast infections, recurrent shingles outbreaks. Thymosin alpha-1 strengthens the underlying immune surveillance that should be preventing these patterns in the first place. Most patients see meaningful reduction in infection frequency within 2 to 3 months of starting therapy. Number 2, long COVID and post-viral syndromes. Karen's lingering brain fog, her exercise intolerance, and unexplained tachycardia after her COVID. She didn't actually get diagnosed with COVID, but she probably had COVID. This is one of the cleanest emerging applications. Long COVID appears to evolve in many patients in a dysregulated immune response to viral antigens that have not been fully cleared. Thymosin alpha-1 supports the T cell function, helps complete viral clearance, and recalibrates an immune system stuck in what we call a partially activated state. Patients with chronic Epstein-Barr reactivation, chronic Lyme symptoms, and post-viral fatigue syndromes also fit this profile. And I have seen this. I have seen patients with long COVID start to feel like themselves again. Autoimmune conditions. This is where bidirectional mechanism is the most important and useful. In autoimmunity, like Hashimoto's, rheumatoid arthritis, lupus, psoriasis, MS, the immune system has lost the ability to discriminate self from foreign. Thymosin alpha-1 helps restore that discrimination by promoting regulatory T cell function, the cells that put the brakes on inappropriate immune attacks. This is not a replacement of disease-modifying therapy in severe autoimmune disease, but it is increasingly used as an adjunct, particularly in elderly or mild presentation like Karen's Hashimoto's. So I'm going to use another analogy to explain that. Think of autoimmunity as a smoke alarm that fires every time you make toast, okay? The alarm itself is fine. The wiring is fine. The problem is its calibration. The system has lost the ability to distinguish between actual smoke and harmless steam from the toaster. Thymosin alpha-1 doesn't disable the alarm. It helps the system relearn what should set it off and what shouldn't. The alarm becomes useful again. The body stops firing on its own breakfast. Kind of think of it that way. And then also number 4, what it's used for, cancer immunotherapy adjunct. This is an emerging application. I want to be careful because the evidence is most established in specific oncologic settings in combination with checkpoint inhibitors and other immunotherapies. In research and clinical trial context, thymosin alpha is being studied in non-small cell lung cancer, melanoma, hepatocellular carcinoma, and several other cancers. It is not a cancer treatment by itself in functional medicine practice or integrative practice, but for patients in active oncology care in coordination with their oncologist, it can be a meaningful supportive therapy. And that has to be managed by someone who knows peptides and also oncology. Okay, and then 5th is vaccine response enhancement. In older adults, vaccines often produce a weaker antibody response than they did when they were younger. Thymosin alpha-1 has been studied as a way to enhance vaccine response in elderly with positive results across multiple trials. For midlife and older patients heading into a vaccination schedule, particularly those with known immune compromise, this is a useful adjunct. And I have mixed feelings here about some of the vaccines. So what I'm going to say is let's strengthen your immune system. That would be my first and foremost objective. But let's talk about the analogy of a vaccine. So vaccine works by showing your immune system a picture of the threat. And then your dendritic cells take the picture, carry it to the lymph nodes, and teach your T cells what to look for. In a young person, this works really nicely, quite beautifully. The picture is taken in high resolution, the lesson is taught with full attention, and the T cells graduate with a clear memory of what to do. In an older person, the picture is kind of grainy. The classroom is half empty, and the lessons barely register. The thymosin alpha sharpens the picture and reopens the classroom, and that's how it helps your immune system get better. The vaccine still does the work. It just finally has an audience capable of learning from it. So hopefully that helps you understand how our immune system works and how thymosin alpha helps an aging immune system. Chronic fatigue and also how vaccines work. Chronic fatigue and energy, this is another indication. Many midlife patients with chronic fatigue have underlying immune dysregulation driving their fatigue. The immune system, when chronically activated at a low level, consumes a tremendous amount of metabolic energy. Restoring the immune balance often translates into measurable improvements in fatigue, even when patients didn't initially identify their fatigue as immune-related. And then cellular aging and health span. And finally, the longevity angle. Because thymic involution is one of the central drivers of immunosenescence, and immunosenescence is one of the central drivers of age-related disease, restoring thymic-style immune signaling is increasingly seen as a health span intervention. The data on this preliminary but biologically rationale is pretty strong. And patients in their 50s and 60s are increasingly using thymosin alpha, not for any specific disease, but just part of a comprehensive longevity protocol. So let me explain that, again, another analogy. Imagine your body as a city and your T cells as the patrol force. In a healthy young city, there are plenty of officers, they're all well-trained, and they know every single block of the city. In an aging city, officers are retire faster than new ones are recruited. The remaining force is older, less mobile, and stretched thin. Crime starts to rise and public health declines. The city itself begins to deteriorate. Thymosin Alpha doesn't hire new officers. What it does is the academy, because the academy is closed, but it does make the existing force more effective, more coordinated, and more responsive. It is the difference between a city in decline and a city that's aging gracefully. And that's why we use it for longevity. Okay, the protocol on how we use Thymosin Alpha in practice. It's administered as a subcutaneous injection. And then there's no effective oral form right now. The molecule is too large and too fragile to survive in the digestive tract. Patients self-administer at home, similar to how a diabetic patient injects insulin. So it's just sub-Q with a small BD insulin syringe. The needles are very small, 31 gauge. Most patients prescribe it, like I said, not more than a little pinch. Especially if you squeeze your skin beforehand, you hardly feel the needle go through. The injection is given subcutaneously, usually in the abdomen or the thigh, typically in the morning or just before bed. The molecule is absorbed into circulation, distributes systematically, and binds to its targets on dendritic cells throughout the body. What's the dosing? The clinically studied dose range is 1.6 milligrams per dose, given subcutaneously with frequency varying by indication. For chronic infection or immune support, twice weekly is common. For active acute infection or post-viral syndrome, more frequent dosing in the early phases is necessary. Sometimes even daily for the first 1 to 2 weeks and tapering down to a maintenance frequency. As always, I don't give specific dosing here on a podcast because, again, it requires a clinical workup and a specific regimen based on your protocol. How long are patients on these? Most patients run about an initially 12-week course to establish whether they're responders. Some patients continue at lower maintenance doses long-term, particularly if they have chronic conditions that benefit from ongoing immune support, chronic viral infection, autoimmunity, recurrent infection patterns. Others use it cyclically, 12 weeks on, 12 weeks off, or seasonally during high-risk infection period times. Kind of think of like school teachers, too, who are exposed to so many kids that have so many runny noses and illnesses. That's kind of a prime time for them. What should you expect? Some patients notice a subtle increase in baseline energy within a few weeks. One thing I hear from my patients a lot is they say oh my gosh, I haven't felt like myself. And I really feel like myself again, especially my long COVID patients. Most patients notice a difference when they don't catch the next thing going around and the cold their kids bring home, the bug at the office. So I see that a lot in practice. It kind of goes from one person to the next. Patients with autoimmune conditions often see a stabilization or reduction in flares over the first 8 to 12 weeks. And patients with long COVID or post-viral syndromes typically see gradual improvement over 12 to 24 weeks, sometimes even longer. This is not a peptide that produces dramatic immediate results. It works in the background, slowly and consistently. The change patients describe most often is the absence of something. The absence of the next infection, the absence of an autoimmune flare, the absence of post-exertional fatigue. They just notice something is different or lack thereof. So always foundations first. Thymosin Alpha works dramatically better when the foundations are in place. That means adequate sleep, because if you have chronic sleep deprivation and you're suppressed the immune function, that's going to happen more than almost any other variable. So when we don't sleep, we get sick, right? Our immune system starts to get suppressed. So it means we want to also have adequate vitamin D. And usually I like serum levels around 80. It means adequate protein. And because your immune cells are protein built, you have to have adequate protein. And also you want to address your chronic stress because cortisol is profoundly immunosuppressive. It means avoiding the things that suppress the thymic function. So again, chronic alcohol, chronic infection burdens, ongoing inflammation, and that's eating a poor diet of processed foods too. What synergies? So thymosin alpha pairs powerfully with several other peptides we have covered and we will be covering. So we've talked about PC157, and you get immune modulation plus tissue repair, useful in autoimmune conditions where there's both inflammation and structural damage. With larazotide, you address the gut barrier component of the immune dysregulation, and since roughly 70% of our immune tissue is in and around the gut, this is important. We haven't talked about this one yet, but CJC ipamorelin will support the thymic environment itself since growth hormone signaling appears to slow thymic involution. That's coming up. Who should you not use thymosin alpha on? It's contraindicated in pregnancy and breastfeeding, not because of any specific evidence of harm. We don't have that, but because of insufficient data. And if we don't have the data, it's probably good not to use it in that environment. We use caution in patients on immunosuppressive therapy because the immunomodulating effect could theoretically interfere with the treatment plan, and any decision to combine should be coordinated with the prescribing specialist. And typically, if someone's coming off an immunosuppressive therapy, that's when I would try it. Or if they maybe have transitioned off of immunosuppressive therapy onto like low-dose naltrexone, and then I want to give an adjunct to the treatment, then I might do thymosin alpha. We also use caution in patients with active organ transplants for the same reason. Otherwise, the safety profile across decades has been pretty remarkably clean. Okay, so I want you to think of thymosin alpha as kind of like the radio that gets your immune team talking again, the dispatcher. So the dispatcher, your dendritic cells, has been at her station all along, but the radio has been broken for years. Calls come in, the team in the field doesn't hear them at all. A crisis escalates without a coordinated response. So if you restore the radio, give the dispatcher back her voice, and suddenly the entire team starts moving in one direction or is one again. Not louder, not faster, just coordinated. That is what thymosin alpha restores. It restores the coordination of what should happen. It doesn't add new capacity. It doesn't make things bigger than they were. It connects what you already had. Okay, so what does this look like for Karen? So here's exactly what we did. Or when I say we, I have a team. We all work together. So I couldn't do my job without my team. So this is what we did. And again, as I always say, sequence matters just as much as the medication or the peptide or whatever we're giving. So first, comprehensive testing. We ran a complete immune panel, including a CD4, CD8 T cell count, the CD4 to CD8 ratio, and a quantitative immunoglobulin panel. We pulled her thyroid antibodies, both TPO and thyroglobulin. We checked her vitamin D, and yes, it was low, 22. We did inflammatory markers, including high-sensitivity CRP and homocysteine. And did you know ferritin is also an inflammatory marker? We looked at her Epstein-Barr titers, given her post-COVID symptoms, and found evidence of chronic reactivation. Her morning cortisol was elevated. Her evening cortisol was flat. Her sex hormone showed estradiol being low, progesterone being very low, and DHEA below the reference range. Then her foundations. Sleep first. Again, strict 10 p.m. wind down with a hard cutoff, and that's the latest. Vitamin D supplementation, aiming for her serum levels to be minimum above 70, closer to 80. Protein at minimum 100 grams per day, and she had to work on stress. We added a structured breathwork practice and a once-a-week therapy session. We removed alcohol entirely from her first 12 weeks, and we treated her gut dysbiosis with a combination of dietary work and gentle antimicrobial, replacement or protocol. Then her targeted protocol started Thymosin Alpha-1 subcutaneously twice weekly. At week 4, we layered in low-dose bioidentical progesterone and a topical estradiol patch to support her hormone function. We added BPC 157 by injection because her gut symptoms warranted true additional repair signaling. At week 12, we evaluated her response and continued Thymosin Alpha-1 at a maintenance frequency of once weekly. And I have to correct that. We didn't give her injection because we didn't have injection at the end of last year. We actually we have oral BPC 157 with KPV, and actually that's what we gave her because we didn't have the injection available. 6 months in, this is how she presented. She had no respiratory infections in the last 5 months, and that was the longest stretch in nearly 2 years that she had not been sick. Her thyroid antibodies were down approximately 40%. Her chronic Epstein-Barr titers were trending down. Her brain fog was resolved. Her exercise tolerance had returned roughly 80% of pre-COVID baseline, and her energy was steady throughout the day. She says she feels, for the first time since in her early 40s, like her body again is working and is on her side. That's what thymosin alpha does in the right patient with the right protocol sequenced in the right order. It isn't magic, it's biology. And we finally gave it back its conductor, so to speak. So what could you do this week, even before you see a physician, about peptides? Get your vitamin D level tested, aim for serum level around 70 to 80, because most midlife adults were deficient or insufficient, and vitamin D is one of the most important modulators of immune function. Inadequate vitamin D will limit how much benefit you get from any immune therapy that we give you. Prioritize sleep with a strict bedtime. Sleep deprivation suppresses your immune function more than almost any other variable. Aim for 7 to 9 hours with a consistent, no later than 10 p.m. bedtime. Track your infection pattern over the last 12 months and write it down. The list itself is pretty diagnostic. If you have had more than 3 infections in a year, more than 2 courses of antibiotics, and any infection that has lingered beyond what feels, quote, normal, that is information you should bring to your clinical visit, especially seeing a functional medicine provider. Address chronic stress as a medical issue, not a lifestyle one. And I have done this many times with many patients. I have a lot of overachievers. Cortisol drives immune dysfunction, whether it's therapy, breath work, structured exercise, or boundary setting at work and at home. The interventions matter less than if there were none, okay? If you have any of the patterns we discussed today, recurrent infections, long COVID symptoms, an autoimmune condition that won't stabilize, persistent fatigue, ask your provider specifically about thymosin Alpha-1 or seek out a functional medicine clinician who's familiar and who has been trained in peptides. So, and that's important because there is a lot of peptide noise right now. And unfortunately, I see some people who have not been trained but may have access to some. And you just really want to make sure they've been trained on how to use them. If you recognize Karen in yourself, if you have caught more illnesses in the last 2 years than the prior 20, and if your body has stopped bouncing back from things that used to be easy, or if you have autoimmune condition that has flared in midlife when it has been quiet for years, it could be a viral infection that has left a shadow you can't shake. I want you to hear something from me. You're not getting older. You are losing your central regulator of your immune function slowly and silently, the same way every other human loses it. So it's all of us. The difference between you and the version of your 25-year-old is it's not effort. It is a signal. The thymus that used to run the show is mostly gone, and nobody told you about that. And because the medical system does not have a name for this in-between space you're in, you're kind of stuck with it, right? But you're not sick enough for an immunologist. So let me tell you, though, that you can get better. You are too symptomatic for living with it. So thymosin alpha is a peptide that takes over the conversation when the thymus gland can no longer have it. It does not regrow the gland. It does not reverse aging, but it restores the orchestration of immune response. The dispatcher's voice, so to speak, the conductor's, that's there, the calibration of a thermostat that has lost its read on the room. Used carefully, sequenced thoroughly, sourced responsibly by a licensed compounding pharmacy is one of the most quietly powerful interventions we have for midlife immune decline. And in a patient like Karen, high functioning, doing all the right things, but losing ground every season is often the difference between a decade of decline and a decade of return. In our next episode, we're going to talk about CJC 1295 and ipamorelin, the growth hormone duo that restores the master signaling cascade behind sleep, recovery, lean body mass, and the entire repair economy of the body. With your gut sealed, because remember, I'm doing this in order for a reason. With your gut sealed, your tissues repaired, so your gut sealed, laryzotide, your tissues repaired, BPC 157, and your immune system back online, thymosin Alpha-1, the next layer is signal restoration, and that's the next episode. If today's episode resonated, share it with someone in your life who quietly is counting their infections, who you think of, gosh, they're always sick, or someone who's been told they have long COVID, but it's in their head. Or maybe they've just been told they have long COVID. Or if you have a family member whose autoimmune condition has been managed but never really resolved, they may really benefit from this episode. Because there is a name for what they're experiencing, there is a molecule that addresses it, and there is a path forward. Thanks for listening. Until next time, I'm Dr. Tracy Page, and I hope you enjoyed Midlife Clarity.
Thanks for joining us today on Midlife Clarity with Dr. Tracy Page. Be sure to subscribe so you don't miss future episodes where we continue to break down the science, the myths, and the mindset shifts around hormones, perimenopause, menopause, metabolism, and the strength for women over 40, so you can feel like yourself again, maybe even better than before. If something in today's conversation resonated with you, share it with a friend who needs to hear it. Midlife health becomes easier when we stop whispering about hormone changes and start having informed, honest conversations. Before we go, a quick reminder. The information shared on this podcast is for educational purposes only and is not intended as medical advice. It does not replace a consultation with your own physician or qualified healthcare provider. Always seek professional medical guidance regarding your personal health concerns. Until next time, stay curious, stay informed, and remember, clarity changes everything.